Hey everyone, welcome to the Optispan podcast. On today's episode, I'm going to talk about three papers that are getting quite a bit of attention in the longevity community, at least on social media. Two of them have to do with our favorite longevity molecule, rapamycin, or vitamin R, as I like to refer to it. And the other has to do with taurine, a supplement that a lot of people are interested in. So let's dive right into to the science here. So the first paper is a study of rapamycin for Alzheimer's disease in humans. And the title of the study is Rapamycin Treatment for Alzheimer's Disease and Related Dementias, a pilot phase 1 clinical trial. Based on a tweet that Alex Zhevronkov put out, Alex's tweet read, "This is a," and then in all caps, "very important study for my friends who believe in rapamycin." I'm not sure what believe in rapamycin means. I think probably what he means is believe that rapamycin is useful in humans. He goes on to say, while this is a very small pilot study with 10 patients and they only dosed 1 milligram for 8 weeks, no aging clocks, it tells many stories about the drug and its presence in the CSF. CSF is cerebrospinal fluid. Read the paper. To which I immediately responded after reading the paper, IMO, this is a useless study that tells us nothing relevant. Wrong dosing, too short, too small. It's an interesting academic question whether higher acute dosing, say 8 milligrams per week, would lead to detectable levels in CSF, but the benefits for dementia might also come from reducing systemic inflammation, not from direct effects on the brain. So there's a lot there. I will say, in hindsight, I probably was a bit too reactionary in my response. And I apologize to the authors for saying this is a useless study that tells us nothing relevant. It does tell us a little bit, but I do think that it is absolutely not an all caps, very important study, and in fact is a very unimportant study. And I'll tell you why. And part of the reason why I responded to Alex's tweet in the way that I did was I felt that the tweet was misleading and designed to mislead people who are wondering whether rapamycin might be useful for Alzheimer's disease into believing that this study suggests that it wouldn't be. And it absolutely does not suggest anything of the sort. So let me tell you why I say that. So the study is small, 10 people. They're all between 55 and 85 years old. They had to go into the study with a clinical diagnosis of mild cognitive impairment or mild dementia due to Alzheimer's disease. The study had no placebo group. The dosing was 1 milligram per day rapamycin daily for 8 weeks. The primary endpoint that they say they set out to measure or to determine was to determine whether you could detect rapamycin in the central nervous system by measuring levels in the cerebrospinal fluid in CSF before and after treatment. And then they had secondary endpoints around safety, cognition, and inflammatory biomarkers in CSF and plasma. So one question immediately is, why did they pick 1 milligram per day? There's no good rationale for that dose as far as I can tell. Again, for those of you who are rapamycin aficionados, you'll know that organ transplant patients typically will take rapamycin daily, but at higher doses than 1 milligram per day, so usually several milligrams per day. And of course, they're going to be taking immunosuppressants and other drugs along with rapamycin. And then in the off-label use of rapamycin, the dosing is typically weekly, once a week, typically in the 4 to 8, sometimes as high as 10 or 12 milligrams once a week. The rationale for the weekly dosing with rapamycin is that you get higher acute levels right after dosing. So the peak levels of the drug in circulation and in tissues is much higher when you dose at a higher dose. And then over a period of several days, that drug is cleared. And so every week you'll have a period where the drug is below the detection limit of the assay, which is about 1 nanogram per mil in blood, and probably close to 0. So before you then dose the next cycle, the next week. The rationale for that is both because it seems like you get better efficacy, at least for age-related endpoints, by dosing once a week. And the best evidence for that has to do with immune response to a vaccine. That's the work of Joan Manick several years ago. But now additional anecdotal data has been collected that seems to be more efficacious and has reduced side effects. And the reduced side effects are at least hypothesized to be due to the fact that you get the trough levels down to 0 before the next dose. That probably alleviates off-target effects on mTOR complex 2. Rapamycin is, of course, a specific inhibitor of mTOR complex 1. There, of course, might be other things that allowing the trough levels to bottom out also does. Regardless, the observation is that the side effects are lower and efficacy seems to be as good or better when you dose once a week as opposed to dosing multiple milligrams every day. The big concern with the daily dosing at multiple milligrams every day are effects on the immune system that might increase risk of infection. It's unclear whether 1 milligram per day would be enough to have those effects on the immune system, but certainly multiple milligrams given daily, you would anticipate a higher likelihood of immune suppression, as well as potentially higher likelihood of negative side effects in terms of glucose homeostasis or lipid levels in the blood. So again, those don't seem to be a problem in the weekly dosing. So I don't know why they did 1 milligram per week, other than this group had previously published a study in healthy people using 1 milligram per week. Again, that was another small study, no placebo group, but they had experience, I guess, and knew something about the safety profile of this dosing. But from a study design perspective, if your goal is to determine are there any effects on cognitive function or are we likely to see rapamycin in CSF, 1 milligram per day is kind of a nonsensical dose to choose. And so why do I say that with respect to CSF dosing? Well, we know, and in fact, this group in their prior study had showed that when you dose daily at 1 milligram per day, you only achieve a peak levels in the blood of between 4 and 8 nanograms per mil. And we also know, given the structure of rapamycin, that at the very, very best, you're going to get maybe 10% the level in CSF that you would see in blood or in serum. And so if we think about that, let's just say 5 nanograms per mil, and we divide by 10, that's 0.5 nanograms per mil. That's below the detection limit of the assay, which is about 1 nanogram per mil. So there was no chance going in that they were going to detect rapamycin in CSF, even if they got a 10% level relative to what's in serum. And actually, it's probably going to be much lower than that, probably 1% maybe. And to add to that, as it turns out, another group had already done the experiment and done it in a much larger setting. So a paper was published a couple of years ago now in Nature Communications that looked at a little bit higher dosing of rapamycin daily. They dosed it a little differently based on surface area rather than just a standard 1 mg per day. It's probably closer to 2 to 4 mgs per day in ALS patients, and in fact showed they didn't detect it in CSF. So not only could we have predicted based on the known peak levels in blood, we wouldn't see it in CSF, somebody else using a higher dose had already showed in 5 times as many people that they didn't see it in CSF. So again, I think it was predictable going in that they would get the results that they got. And indeed, that's what they got. They couldn't detect it in CSF because even if it's there, it's below the detection limit of the assay. Okay, why do we care if rapamycin's in CSF? Let's table that. I'll come back to that because I think this is really the more interesting part of the discussion. But, you know, I'm not really sure what to say about the fact that they didn't see it in CSF, except that's what you'd expect. And I guess I kind of feel sorry for the people who underwent multiple lumbar punctures to discover something that we could have predicted in advance. What else did we learn besides the fact that you're not going to see rapamycin in CSF at this dose? The side effects, again, were pretty minimal. We can't actually tell if they're any different than they would have been with the placebo group because there was no placebo group, but they were pretty minimal in any case at this dose. And then there were some changes in inflammatory and AD-associated markers that if you really wanted to, you could potentially make a case that these are interpreted as going in the wrong direction. And I say if you really wanted to, because you really have to stretch to feel confident about that interpretation when you actually look at the data. Because when you look at the data, in my view, it's hard to be confident about much of anything. And so some of the markers that they looked at included phosphorylated tau, a marker of Alzheimer's disease, GFAP, which is a marker of neuronal inflammation, and neurofilament light chain, another marker of dementia. This is now in CSF and in blood. And what they saw was that for those three in the rapamycin treated group over time, so this is going from baseline to the end of the study, because remember, we didn't have a placebo to compare it to, there was a slight but statistically significant increase in these three markers. Why I say that's hard to interpret is if you look at the variation just across the participants in the study, the variation across the participants at baseline and at the end is much greater than the small change that you see over the course of the study, over the course of the rapamycin treatment. So while it might be statistically significant when you pool all of the individuals, all of these people have mild cognitive impairment or clinical symptomology from a cognitive functional perspective of Alzheimer's disease, and yet their variance in these markers is much greater than the change over the course of the study. And then, of course, without a placebo group, we don't know if that change over the course of the study was because of rapamycin, attenuated by rapamycin, whether that's what you would have seen just with normal progression of the disease over the length of time that the study was happening. So again, really, really hard to interpret anything, I think, from the way the study was designed. And in fact, the authors agree with this in their discussion. They say, and I'm quoting now from the paper, without a placebo-controlled group, we are unable to clearly determine if the outcomes observed are due to the study drug, natural disease progression, or other unexplored factors. Basically, we can't conclude anything. So if we now go back to the original tweet from Alex, I just don't see how you conclude in any way, shape, or form that this is an all caps, very important study that tells lots of stories about rapamycin. I don't think it really tells us much of anything about rapamycin or its utility for Alzheimer's disease. So again, I overreacted in my tweet. I apologize to the authors. I think what bothered me was that this tweet, again, I'm not going to pretend to know any intention here. The outcome is that the way this was presented misleads people into thinking there's something here that there just isn't. So I don't think there's a lot that we can conclude from this study. Now, what about the question of why would we even be interested in whether we can measure rapamycin in cerebrospinal fluid in the context of its potential effects on Alzheimer's disease, other dementias, other brain-related function? And I think this is actually a really interesting question, and particularly in the context of the once-weekly dosing. So you give a higher amount of rapamycin, let's just say 8 mg once a week, you're going to get a higher peak level in circulation. Would that actually get to the level that you can detect it in cerebrospinal fluid? Fortunately, I think we're going to find out because there is a clinical trial happening called ERAP. It's a phase 2A clinical trial. The protocol has been published, so we don't have the data yet, but they've described the protocol where they're going to be dosing people for Alzheimer's disease at 7 milligrams once a week. This looks like a pretty solid study design to me. So they're going to look at CSF rapamycin levels, blood rapamycin levels. I should say the study that I just talked about that did 1 milligram per day did not actually measure rapamycin in blood in those same people. Again, I'm not sure why you would think you would want to do that, but it wasn't in the paper. This study, again, they're going to dose 7 milligrams weekly, once a week. They're going to measure rapamycin in blood, rapamycin in CSF. They're going to look at cognitive function. They're going to look at PET imaging for neuronal activity, which we know is reduced in Alzheimer's disease. And they're going to look at MRI for brain region volume, which again, we know as Alzheimer's disease progresses, there are changes in different regions of the brain where you see decreases in brain volume. So I'm enthusiastic about this trial, and I'm obviously interested to see what they determine, and I feel better about the dosing strategy in this trial compared to 1 milligram per day. So it'll be very interesting to see outcomes from this study. But I will add, I'm not sure that detecting rapamycin in CSF is essential for potential effects of rapamycin on the brain. So it's been sort of talked about for a long time that rapamycin doesn't cross the blood-brain barrier, or doesn't at least cross it very efficiently. Lots of questions about whether when you treat even mice with rapamycin, it gets into the brain in significant concentrations. That's actually a pretty answerable question. It's kind of surprising that people still debate this, but that is a debate. A lot of people will say it doesn't cross the blood-brain barrier. And yet we know in mice, when you treat them with rapamycin, biochemically, we can see very potent inhibition of mTOR by using a whole bunch of different biochemical markers. Lots and lots of labs have done this. So even if rapamycin isn't getting to the brain at high concentrations, we're still seeing the anticipated effect of rapamycin, which is inhibition of mTOR. And I think a super interesting question is it possible that systemic effects of rapamycin on mTOR are leading to inhibition of mTOR in the brain, even if rapamycin isn't causing that inhibition directly? You could imagine metabolic changes, different metabolic substrates, changes in inflammatory signaling that could indirectly be affecting mTOR in the brain. Again, that's an answerable question, but at the end of the day, as long as mTOR is being inhibited in the brain, then we would anticipate that we might get the benefits from rapamycin in people that we see in mice. So my only point is it doesn't necessarily have to be the case that rapamycin is getting to the brain. If it works, it works. So let's just find out if it works. Okay. And the last thing I'll say is, again, it's very early, but the early data is kind of interesting that at least in people who are genetically predisposed to Alzheimer's disease, because they have the ApoE4 allele, there were a couple of papers that have come out recently suggesting that rapamycin treatment in ApoE4 carriers can improve both early changes in brain volume and cerebral blood flow, which again, we know is declining in Alzheimer's disease. So they're both small studies. I've talked about them on the podcast before if you're interested, but I do think this is strongly suggestive that rapamycin may indeed have benefits for Alzheimer's disease, or at least for people who are at higher risk of Alzheimer's disease because they are ApoE4 carriers or homozygous. And so early, interesting, intriguing, and I think there's reason for optimism that rapamycin could help, at least for a subset of people who are on the path to dementia. Okay, so that's the first paper. The second rapamycin paper I want to talk about is one that I think actually has a lot more to say. This is a new study. It's a preprint, so it has not been peer-reviewed yet. It's currently under review at the Journal of Translational Medicine. The title of this paper is Low-Dose Rapamycin Alleviates Clinical Symptoms of Fatigue and PEM, that's post-exercise malaise, so exercise intolerance, in chronic fatigue syndrome patients via improvement of autophagy. And I'll just mention one of the co-authors on this study is John Berner, who's been on the podcast before. So again, I'll refer you to that episode where I interviewed John if you're more interested in his work. He talks a lot about rapamycin, but also other topics like lithium and other medications. So the background here is that a subset of the authors from this study have previously shown that an inactive form of a protein called ATG13 is increased in patients with chronic fatigue syndrome. And ATG13 is involved in autophagy. That's what the ATG stands for. And so their hypothesis is that impaired autophagy is causal for chronic fatigue syndrome in at least a subset of people, and that the reason autophagy is becoming impaired is because of hyperactivation of mTOR. And of course, again, rapamycin is an inhibitor of mTOR. So the model here would be that you have hyperactivation of mTOR leads to impaired autophagy through ATG13. That leads to chronic fatigue syndrome and all of the symptoms that are downstream of chronic fatigue syndrome. Consistent with that, a mouse knockout of ATG13 has muscle weakness and exercise intolerance, which are symptoms associated with chronic fatigue syndrome. And so again, if that model's correct, the prediction would be if we can block the hyperactivation of mTOR with rapamycin, we might be able to improve the symptoms associated with chronic fatigue syndrome. Okay, so they refer a lot to ME/CFS, that's myalgic encephalomyelitis / chronic fatigue syndrome. I'm just going to call it CFS or chronic fatigue syndrome so I don't have to say myalgic encephalomyelitis a bunch of times because I will inevitably screw that up if I try to say it too many times. Okay, so I'm going to take you through the abstract and just give you a little bit of commentary, and then I'll briefly talk about what's in the paper. So the abstract background reads, mTOR activation is associated with chronic inflammation in chronic fatigue syndrome. Previous studies have shown that sustained mTOR activation can cause chronic muscle fatigue by inhibiting ATG13-mediated autophagy. This highlights the pivotal role of mTOR in the pathogenesis of chronic fatigue syndrome. So that's that model I just took you through. Hyperactivation of mTOR, inhibition of ATG13, impaired autophagy, chronic fatigue syndrome. Okay. The study methods. We conducted a decentralized, uncontrolled trial of rapamycin in 86 patients with chronic fatigue syndrome to evaluate its safety and efficacy. Okay, so decentralized just means lots of clinics are involved, not a single clinical site. Uncontrolled means no placebo group in this case. They used low-dose rapamycin, 6 milligrams once a week. So this is getting to the more standard off-label dosing that we talked about just a few minutes ago. Low-dose rapamycin, 6 milligrams per week, was administered, and core chronic fatigue syndrome symptoms were assessed on days 30, that's T1, 60, T2, time point 2, and 90, time point 3. So 90 days of treatment. I'll talk a little bit more about that in just a second. They measured plasma levels of autophagy metabolites, such as phosphoserine 258 ATG13. That's just the inactivated form of ATG13. For those of you who really care about the biochemistry here, that phosphoserine 258, that's a phosphorylation on ATG13. mTOR is a kinase, a protein that puts phosphate groups onto other proteins. So this is a downstream consequence of mTOR hyperactivation, is this phosphorylation of ATG13. The other autophagy marker they measured is called Beclin-1. Those were measured and correlated with the clinical outcomes of chronic fatigue syndrome. And we'll talk a little bit more about what specifically they looked at in terms of symptomology. Again, multiple clinics, no placebo, outcomes were symptoms and blood measures of autophagy. They also measured a bunch of clinical blood biomarkers, and we'll get into that a little bit. Some interesting data here on glucose and lipids that I think are relevant to the perception that rapamycin may have side effects in those domains. The design of the study, again, pretty interesting. This graphic, I think, does a good job of sort of illustrating what was done. Turns out they weren't dosed with 6 milligrams rapamycin for the entire 90 days. The first month or so was a dose escalation, so they started low and went up to 6 milligrams a week. Then from 30 days to 60 days, they were at 6 milligrams per week, and from 60 days to 90 days, they were at 6 milligrams per week. Okay, so here are the results. Rapamycin, 6 milligrams per week, was tolerated without any significant adverse events. That's good. Of the 40 patients, so 40 people went all the way through the trial. And that's actually a pretty significant fall off from the 80 some that were initially enrolled. They don't really describe all of the reasons that people were lost, but one of the reasons they cite is that this study, because of the way it was designed and funded, was not financially supporting the participation of the patients and was not paying for the study medications. This was all out of pocket for the people participating. That's one of the challenges of this kind of a distributed clinical trial design. You tend to have a lot of drop-off over the course of the study because of the way that the study is being done, and there's no incentive for the participants. So in any case, 40 people completed the study. Of those 40, 29, almost 3/4, showed strong recovery in PEM, post-exercise malaise, fatigue, and OI, along with improvements in MFI fatigue. So these are now symptomatic measurements of chronic fatigue syndrome. And MFI is multidimensional fatigue inventory, so a survey-based way of assessing chronic fatigue. Okay. And SF-36, so another quality of life survey instrument, very well validated. High levels of Beclin-1 were detected in T3, plasma ATG13 levels, the phosphoserine 258 ATG13 levels were strongly downregulated at T1. That's what you would expect from rapamycin. And then Spearman's correlation analysis indicated an association between autophagy impairment and reduced activity. Okay, great. Conclusions. Low-dose rapamycin effectively reduced PEM, so post-exercise malaise, and other key symptoms in patients with chronic fatigue syndrome, as measured by a whole bunch of survey tools. Future studies should encompass dose optimization and develop a diagnostic tool to identify responders with mTOR-mediated autophagy disruption. So they're referring to their interpretation that the 3/4 of people who showed symptomatic improvement were the people who had this impaired autophagy, and that's how rapamycin is working. I don't know that that's really strongly supported here, but certainly it did seem to be that there were responders and non-responders. Okay, so what are some of the limitations? Just like the first study, no placebo group. Another limitation is that their functional improvements were largely patient-reported. You always have to be a little bit careful about survey-based patient-reported outcomes, but in general, these are validated survey tools, so you can feel pretty confident in their use. I think the lack of the placebo group here, it's pretty easy to imagine a placebo effect because these are patient-reported fatigue-based outcomes. The placebo effect could have a real impact here. But I will say the molecular markers they used argue against that as the sole mechanism, but it is certainly possible that there was a significant placebo effect at play here where the people they knew they were taking rapamycin, and so they felt better. That's hard to rule out. That's why we have a placebo group. They didn't have a placebo group. The other thing that I thought was interesting is they did not use any standard generic formulation of rapamycin. The patients were prescribed rapamycin by their physician, and then they filled them at their own pharmacy of choice. So people were potentially taking different formulations of rapamycin based on where they got it and what the prescription was specifically for. The reason why that's relevant is we've learned that some compounded forms of rapamycin have lower bioavailability, even down to maybe 25% that of the generic Rapamune or generic sirolimus tablets. So we don't know, at least they didn't say what the different formulations were that the different participants in the study were using. Okay, so let's talk about the results. This is where I think I look at this study and this looks real to me. So they looked at a lot of different outcomes. They used something called the Bell Activity Scale, which showed a significant improvement in physical activity. The p-value here was quite impressive, 0.0001. And we can compare that to the prior study where they were looking at some of these blood-based biomarkers and the p-values were right around 0.05, which is the typical cutoff. So this looks to be very strong signal for that particular readout. They also used a symptom severity scale where they showed significant improvements in fatigue, sleep quality, and post-exercise malaise or post-exertional malaise. Again, all p-values less than 0.0001. So again, quite a strong effect. And then on the SF-36 quality of life survey, they showed statistically significant improvements in physical functioning, emotional well-being, energy and fatigue, social functioning. So across all of the domains that this survey measures, we saw statistically significant improvements. So when you start to see everything lining up in the same direction and the effect size is very strong, that obviously gives some confidence that these are probably real effects, that at least from the patient perspective, because this is all patient reported, they felt a lot better. I think there were some interesting additional features about this study. I like the distributed clinical trial design. I think we'll see more and more of those, multiple docs. And these are real people with real conditions in the real world. I think that's important. For all of the weaknesses of not having a placebo group and different formulations of the drug, that's what the real world is like. And so I think in some ways this mimics the real world maybe better than a sort of traditional clinical trial design. Um, I also thought it was interesting that the post-infectious chronic fatigue syndrome patients were the best responders. And so what this is referring to is many cases of chronic fatigue syndrome follow moderate or severe viral infections. So long COVID being one example of this class of patients. The classical sort of example of this is after an Epstein-Barr viral infection. Also, sometimes even after bad influenza infections, people will be diagnosed with chronic fatigue syndrome. And what they saw were the best responders to rapamycin were the people whose CFS was following a severe viral infection. And that fits with, I think, some accumulating evidence that Rapa has pretty potent benefits in the context of chronic viral induced inflammatory conditions. So this just is adding additional evidence to that idea. I think also the fact that rapamycin seemed to be very well tolerated in this group. Again, we're using kind of fairly standard off-label dosing, 6 milligrams once a week, low incidence of adverse events. Those adverse events, which were mild, were transient. So again, this fits with the accumulating evidence that for most people at this dose, they don't experience any significant side effects. No evidence here of increased immunosuppression or susceptibility to infections. Again, just adding additional evidence for the safety of this sort of once weekly dosing of rapamycin. And in a population that, is experiencing a significant health concern in the form of a pretty dramatic chronic fatigue syndrome. Again, I think it's worth saying these patients are probably not people who have mild cases of CSF. These are people who are really having their quality of life impaired by this condition. So that's, I think, encouraging. Again, more data that this dosage of rapamycin is pretty safe. Okay, so I also thought it was informative that they looked at some of the clinical chemistry parameters relevant to metabolic dysfunction, because there are a lot of people who talk about the risks of rapamycin for diabetes and hyperlipidemia, right? So, but very little data, the people are just talking about it in the absence of data. This study actually measured a whole panel of common clinical blood biomarkers and really saw nothing from rapamycin. And in particular, I want to point out there were no changes in hemoglobin A1C, a marker of glucose homeostasis. There were no changes in fasting blood glucose. There were no changes in triglycerides. There were no changes in high-density lipoprotein. There were no changes in low-density lipoprotein. So no evidence for metabolic or lipid derangement in this population at 6 milligrams once a week over a 3-month period. Now, we don't know what happens when you go longer than 3 months, but at least over this time frame, really doesn't seem to be any reason to believe that there are any risks from rapamycin for glucoregulatory biomarkers or blood lipids. Okay, so that's reassuring. So again, my overall take is this looks real. It seems like rapamycin pretty dramatically improves symptoms of chronic fatigue syndrome in, let's call it 75% of people, at least the patient population in this study, and in particular in people whose chronic fatigue syndrome is following a significant viral infection. They're potentially more likely to be responsive to rapamycin, no significant side effects, and no evidence for changes in glucose homeostasis or blood lipids. Seems to be safe and effective over a 3-month period. So again, there are some weaknesses to this study, but to my eye, this looks real. And again, this is not medical advice, but my personal opinion is I would say anyone who's got moderate or severe chronic fatigue syndrome might want to consider trying this rapamycin regimen just to see if it helps. If it doesn't help, okay, move on. If it does, that's a win. So that would be kind of my take on where this stands. And obviously, we want to see larger studies, more studies. Like nobody's going to argue against a randomized, placebo-controlled clinical trial, but I'm not sure we need it in order for people to start benefiting from this kind of therapy. And I think this study makes a pretty compelling case that if you're in that group, you might want to consider it, or at least talk to your physician about trying rapamycin. That's study number 2. Study number 3 has to do with taurine. Taurine is a natural product. It's being sold as a supplement. It got a lot of interest, I think, in the longevity space based on a paper that was published a couple of years ago reporting 2 things. Well, more than 2 things, but 2 things I'm going to focus on for today. One is that in mice, monkeys, and people, there is an age-related decline in taurine, at least across the population on average, and that supplementing with taurine can increase lifespan in worms, flies, and mice, have positive impacts on some health metrics in monkeys, although not a lot was assessed in monkeys. And there's some correlative evidence in people that taurine levels are associated with positive health outcomes. So that study was published in 2023. This new study, which was published in Science, called into question the first of those things, whether or not taurine levels actually decline significantly across the population as a function of age. Okay, and I should say, full disclosure, I was a co-author on the first study, the one from 2023. I didn't have anything to do with the assessments of taurine concentration with age, didn't have anything to do with the studies in mice, monkeys, or people. My lab did a little bit of work in yeast and C. elegans for this paper. So I have said it before, I'll say it again, I had a pretty minor role in that study. I think that study was a good study. I think a very interesting study. And I don't think my interpretation of this new study is being affected by the fact I was a co-author on that prior paper, but I'll just put that out there. The reason I say I don't think it's affecting my opinion is because what I'm going to tell you is I kind of think this new study is mostly a big nothing burger. Like, I am shocked that this study was published in Science given what it did and more precisely did not show. Okay, so as I mentioned, I think the new study, which is titled "Is Taurine an Aging Biomarker?" Was well done. Like, I think for what they did, it was extremely well done. It's a comprehensive study, looked at longitudinal data from humans, monkeys, and mice. And what they show pretty convincingly is, at least in their groups, they did not see a significant decline in taurine levels in blood with age. And so I think it does call into question that part of the original study, whether or not taurine is a universal biomarker of age, right? In the sense that its levels go down with age. I think this study calls that into question. What it doesn't do is tell us anything about whether taurine is a useful therapy for targeting aging. And I think that's the big weakness of this study. And so one thing you might be wondering is whether or not this new study should influence your enthusiasm for taking taurine as a supplement. I can't really obviously answer that for you. For me, it doesn't change anything, but I don't take taurine. I've never recommended people take taurine. I think the original results suggesting taurine can increase lifespan in worms, flies, and mice are intriguing. As I've sort of already said, there's nothing in this new study that addresses that one way or the other, but I'm also not somebody who goes right from a single mouse study and starts taking things or suggests that other people should start taking things. So it doesn't really influence the way I think about taurine as a supplement, and I'm not sure that it really should change the way you think about taurine as a supplement. So it's funny because there was a press release that was put out about this study. Again, Science is obviously a high-profile journal, where one of the study authors said, quote, that it caused them to conclude that the efficacy of taurine supplementation to delay aging or broadly treat aging-related conditions may be context-dependent. I think that's kind of a funny quote because it doesn't really say anything. I mean, I don't mean anything against the person who said it, but that's a non-statement. Of course it's context-dependent. Everything's context-dependent. And there's nothing in this paper that tells us anything about the efficacy of taurine supplementation to delay aging or broadly treat aging-related conditions. I don't think there's any data here one way or the other about that particular question. It's not completely fair for me to be dismissive of this study because there is indeed some value to showing rigorously that the connection between taurine levels and age is complicated and perhaps not very convincing. I guess what I struggle with is whether or not the hundreds of thousands or probably millions of dollars that were spent on this study could have been put to better use elsewhere. Because I don't know anyone who ever argued that taurine was a good biomarker of aging. I haven't heard anybody talking about taurine clocks. So I don't know how important it was to disprove that you can't build a taurine aging clock. I guess I just don't see why that's the important question. I think the much more important question is supplementing with taurine actually a useful intervention for slowing biological aging? I really, really wish they had done that experiment in addition to providing evidence that taurine levels may not decline with age in different animals. Because I think if they were able to reproduce the lifespan extension and health span effects of taurine, that would have been great. We would have more confidence in that result. If they were unable to reproduce that, that would have not been great, but it would have at least added some questions to where we could say, okay, maybe the likelihood that taurine is a useful or robust longevity intervention is lower. But they didn't do that. They didn't do the hard experiment. They did the easy experiment, which is less informative. That, I guess, is where my frustration is, that I don't think a publication in Science should avoid doing the important experiment, which in my view, actually attempting to replicate the longevity and health benefits is the important experiment here. So to sum up, I think two of these studies were pretty disappointing to me. The first study of rapamycin in AD, where they used 1 milligram per week, didn't really learn anything from that. The second study in Science about taurine, I think we learned again that taurine is perhaps not a robust biomarker of age, and that across populations, it may not, probably doesn't universally decline with age, but it didn't tell us anything about whether it's a useful intervention for targeting aging. The third study I actually thought probably underappreciated, but potentially really important, where I think the results, even despite the limitations of the study, are pretty convincing that for a significant fraction of people with chronic fatigue syndrome, a pretty standard now dose of rapamycin, 6 milligrams once per week, may be quite effective at alleviating symptoms. And that should be very encouraging for people who are struggling with this condition, and also provides additional evidence that for viral-mediated long-term inflammatory outcomes, rapamycin may be particularly useful for those types of conditions. So I'm pretty enthusiastic about the CFS connection, and am looking forward to seeing what additional data comes from ongoing studies in that area. So as always, thank you for watching this episode of the Optispan podcast. Please feel free to ask any questions. Please feel free to tell me why I'm wrong about the two studies I wasn't very excited about. And I hope to see you next time on the Optispan podcast.